So welcome everybody. Thank you for joining us tonight. My name is Janelle Devereaux. I'm the Executive Director for Health Systems Integration at North Western Melbourne Primary Health Network. And we're here today to share the expertise of two fantastic GPs that have been doing a huge amount of work to manage COVID in the community over the last, 18, 20 or so months in Melbourne. Now, I'd like to start by acknowledging that we're meeting on Aboriginal land today and pay my respects to elders past, present and emerging. I'd like to acknowledge I'm coming to you from Wurundjeri country and would like to acknowledge the people of the Kulin Nation as well as the traditional custodians on the land on which we're meeting today. I'd like to recognise their continuing connection to the land, waters and culture, and again pay my respects to those with us this evening. So just a little bit of housekeeping before we move on. All attendees have been muted, so I just would like to make a note that the question and answer function that is circled there on the right is available for you to ask questions. I'll be keeping an eye on that along with Claire, my colleague from the PHN in the background. Please use that function to ask questions and we will answer those as we go as best we can. Otherwise, I'll keep a track of them and I will theme any questions together and ask our two speakers once we get to the end of the session, and there'll be plenty of time for you to ask questions then. Just to let you know that the session is being recorded tonight, we would like to be able to make this available to those that can't be with us this evening. You will also send this link to you. But your questions will be anonymous just to make sure that we protect your privacy. And please just make sure that your name and your Zoom webinar is correct. We've had some very entertaining names and photos from the days when children were also schooling from home, which has provided a bit of an entertainment for those of us that have been in lockdown for what feels like the best part of a couple of years. So the agenda tonight, clearly I'm giving the introduction and then we've got two fantastic speakers. So we'll start with Dr. Catherine Orr, who will talk to us about managing COVID positive patients in the community and outline some risk factors and importance for GPs. Then Dr. Elizabeth Williams will follow and will share with us some of the information about types of presentations and about managing multiple family members. We learned very quickly, particularly with the numerous lockdowns and waves this year, that working with households in a holistic way was really important. So I think this is great for us to be able to hear a bit more about that. And then, as I mentioned, there'll be question and answer time towards the end, and I'll wrap up at 7:30. So a bit of information about our wonderful speakers tonight. Dr. Catherine Orr is a GP with Co-Health, but has vast experience in Aboriginal health, sexual health, and has also worked locally and published locally in terms of work associated with sexual health and COVID-19, which you can see from the bio there. And Dr. Elizabeth Williams leads the COVID Safe group at her practice in Melbourne's northern suburbs, both areas of which Catherine and Elizabeth have worked, has really experienced quite high numbers of COVID cases. So hence why we're bringing them to share their expertise with you this evening. But it's enough from me. We'd like to hear from these speakers. So what I will do is hand over, without further ado, to Catherine.
Hi, everybody. I'll just get my slides going. So my name's Catherine Orr. I work for Co-Health, which is a big community health organisation in Western Melbourne. And I've been involved in COVID testing and vaccination and management of COVID positive people. I think I've managed over 200 COVID positive people and their families over the last 20 months. And going from, it really has evolved from when people would receive a call from either the testing GP or the testing clinic to say you've tested positive for COVID, stay home for 2 weeks, to now a really excellent wraparound service where people's health needs are met, their social needs are met, and families are managed as a whole. And it's really evolved into an excellent service, and based on the model that was started in the north and the west of Melbourne, and is going to be replicated, I think, throughout Australia, with Health Direct as the agency doing the initial assessment. So it's been a really interesting journey. Just wanted to talk firstly about the model, and it's a West Metro COVID care pathway. So I'm talking about our model, but I think a lot of the principles apply to COVID management of anybody in Australia. So it's a virtual care model, which is aimed to optimise care for people who can manage in the community, don't need hospital admission. It includes a risk assessment at the time of notification of COVID infection and streams patients into tiers of care based on risk factors and current symptoms. Importantly, excludes people residing in residential care, hotel quarantine or other accommodation that wouldn't be suitable for virtual care. The aims of the model are to assess and review patients at given intervals. So depending on the illness of the patient and also the capacity of GPs, the patients are reviewed regularly. It's important to monitor for signs of deterioration, because we know that COVID patients can go from being relatively mild symptoms to deteriorating quite quickly, and to know pathways how to escalate care if patients need to move upstream from low risk to medium risk or to inpatient hospital care. And it's a parallel process to the ones provided by the local public health unit, who are responsible for collating the positive people in the various public health units within the cities and towns, and allocating the assessment of patients to various organisations, which is in the West, it's CoHealth. So the process, how patients are enrolled in the pathway, which really describes CoHealth's role, but I think over time it will be Health Direct's role across various states in Australia. So the public health unit provides a COVID positive patient list daily for triage by CoHealth. So CoHealth then, we have care navigators that ring the patient and do an assessment of clinical status at that time of the call. So at that point, if they need inpatient care and an ambulance called, then it's called at that time. And if not, then they're streamed into the different, just whichever stream they're appropriate based on the stage of their illness, severity of disease, age and comorbidities. The really important thing, because we learned very early on that most people do want to do the right thing and stay at home and not infect anyone else, but often social needs or medication needs or psychosocial risks meant that they couldn't stay at home. So it's become a really critical part of supporting people to stay at home. So it's important to identify those barriers to being able to isolate safely at home. So they're streamed into a particular level and referred on to care, also given general advice and counselling about COVID-19, and the patient is the patient's expectation regarding the role of the public health unit and who will be ringing them in the next few days is established. So we have a clinical risk assessment. So over time, we've been able to work out which patients fall into mild, moderate and severe symptoms. So someone mild has no shortness of breath at rest. They have some shortness of breath on moderate exertion. So it's important to ask people, what can you do if you're walking around the house, if you're talking, if you're coughing, if you're walking up and down flights of stairs, so that sort of thing. So sometimes we do actually do a bit of a test of their shortness of breath while they're on the phone. And then moderate symptoms is higher degrees of shortness of breath and some systemic symptoms. Severe symptoms, shortness of breath at rest, chest pain, and syncope, interestingly, has become a quite important symptom. So it's important also to recognise risk factors for severe disease in COVID-19. So these are all individual risk factors. So we know that if people deteriorate, they generally deteriorate between day 5 and day 10 of the illness. So most people these days are having symptoms and being tested within a day or two, but there are still a significant number of people who delay testing. So at the point of that initial phone call, they actually may be day 7 of their illness, even though they're only day 1 of their since their positive test. So it's really important to ask about the onset of symptoms and work out which day in the illness they're in. Pre-existing cardiovascular disease, diabetes, respiratory disease, immunocompromise. I mean, a lot of these are obvious, Obesity was one that probably potentially wasn't so obvious, but it's definitely become a clear risk factor for severe disease. Active smoking at age over 60. And of course, vaccination status has become probably one of the most overriding risk factors for severe disease. So we, as you will all be well aware, that vaccination, we've been very lucky, thank you to scientists to develop such great vaccines in such a short amount of time that have really good protection against severe illness and death. And Australia proudly has a very high vaccination rate, which is great. So that's also a really critical thing to establish when you ring the patient. So this is just the streams that patients are streamed into. So we've got intensive primary care management, which is where GPs step in. So they're considered the low risk stream, and they're managed by telehealth, preferably by their regular GP. So we ask all patients who their regular GP is, and we definitely as a priority try and link them into them. But we have a process for linking patients who may not have a regular GP or who also may not have Medicare. So it becomes difficult for GPs to manage. Most GPs will manage 1 or 2 patients without Medicare, but if some of the people without Medicare are international students who've lost their income and are not eligible for any Centrelink benefits or Medicare, and so those patients are managed by GPs working within community health organisations who are not relying on Medicare billings. At the moment, we're using a system called REDCap, but ignore that because that's changing very quickly and it won't be transferable interstate. So the medium stream is hospital-led home care. So that may be hospital in the home, or it may be what's described as virtual ward. So this is daily telehealth contact rather than second daily, and includes delivery of oxygen saturation monitors and thermometers and a bit more intensive management. And at the moment that's being provided in the West by Calvary Medibank team. And then hospital-led home care. So that's where the hospital in the region the patient lives in takes over their care, and it's just may involve daily on-site visits with a nurse. And then obviously they scale up to inpatient care. So it's important to know if you're operating in the GP model, how to escalate your patients up to the medium care stream and what sort of things you need to be looking for in terms of signs of deterioration. So I just want to talk quickly about a couple of specific categories, because we know, starting with pregnant people, that pregnant people do very poorly with COVID-19. So they are not appropriate for GP care under the model in the West. And all pregnant people are referred to the medium stream for hospital-based care, co-managed with their obstetric provider, particularly pregnant people coming close to their delivery date. Children with COVID-19 has been an evolving space. Generally, if a child is in a household where there's an adult positive for COVID-19, then the child is not streamed separately. So that family is managed as part of a household. And when we check in with the COVID positive adult in the house, we check on any of COVID positive children or negative children to see if they've developed symptoms and might need an in-house test. Because it's really important in a family unit, I'm sure Elizabeth will talk more about this, that if family members have developed COVID, they become symptomatic, that you get that positive diagnosis as soon as possible to minimise the delays for isolation for families, because it can drag on. It's important that vulnerable children or children with medical comorbidities are streamed and are actually linked into care, and they may be linked into care with their GP, but they also, if they've become quite unwell, then they may be linked into care with the relevant children's hospital. Sometimes we have families with complex social issues, and teenagers and children with families with complex social issues. And at the moment they're supported by CoHealth, but it's really important to recognise those issues in families, because that's when staying at home and isolating becomes very difficult. And families with complex social issues, drug and alcohol issues, mental health, find isolating for serial periods of time, because various members of the family sequentially test positive, a very, very stressful situation. And so it's really important to support families with whatever services they need. So there's just some rapidly evolving space in terms of therapeutics for COVID-19, which is really exciting because I think vaccinations plus therapeutics is really going to be a game changer for COVID-19. So we have inhaled budesonide, which has some criteria: adults with symptoms starting on day 1 to 7, age 65 or over, or younger adults with comorbidities. And that can be prescribed in the usual fashion by the treating GP using e-scripts or whatever you're using for your provision of scripts for patients being managed by telehealth. The other therapeutic that's being used widely is sotrovimab, which is for symptomatic adults, including pregnant women. And there's a criteria for eligibility for sotrovimab treatment. And there are the oral treatment, which name has slipped my mind, Elizabeth, you might know it, but that's coming on board at the moment in the West as well. So adults who have one or more of the following risk factors are eligible for sotrovimab treatment. It's really important that you identify patients who meet eligibility criteria for therapeutics, because particularly with sotrovimab, it's a single infusion that has to be delivered at the moment within a hospital setting, but hopefully that will change. And it has to be within the first 5 days of symptom onset. So you need to recognise somebody who is unvaccinated and has risk factors and eligibility for sotrovimab, and know the referral pathways within your system for getting them assessed and for treatment, as you may miss that window otherwise. So what's the management of patients you can't contact? So, you know, as GPs, we've all pivoted to telehealth, and you ring a patient, they don't respond, and we've got to know how urgent it is to chase that patient more intensively. So you need to consider the patient, whether you've previously made contact with them. Often if you're ringing them every second day and you've got to day 8 and they're asymptomatic and you know they're going to have clearance in the next couple of days and you can't contact them, it's probably no big deal. And sometimes just sending an SMS is helpful, because these people do get an inordinate number of phone calls from lots of different people. And so I found using an SMS was really helpful. Hi, it's Dr. Catherine. I spoke to you on Wednesday. Can't get hold of you today. I'm hoping you're still feeling well. Something like that. And I got a very good response rate using that technique. Obvious. I mean, these things are all obvious to GPs, whether they were a risk factor for deterioration, whether they lived alone, and just consider other alternative methods of contact, as talked about with SMSs. Calling from a blocked number is a real problem. Not all GPs have a work mobile and a home mobile, but if you do have if you're finding you're not getting people picking up, it's usually because it's a private number and a lot of people don't answer them. COVID patients in the first 5 days of illness are often a bit fluey and not real good first thing in the morning. So I found scheduling my COVID phone calls to the afternoon meant I had a better response rate as well. Generally, I didn't want to put specifically what we do in the West if you really can't get hold of a patient, but generally it's contacting the public health unit and letting them know that that patient you haven't been able to contact the patient, and so they can do some more escalation about their well-being. So what are the risk factors and situations where we might want to escalate a patient from the low risk GP care up to the medium stream? So usually COVID, you get to know the pattern of behaviour of COVID illness, and you can, when you're phoning them, you can demonstrate this pattern of stability or gradual improvement over time. If you feel that when you're ringing the patient, they're reporting more and more symptoms over time, particularly the chest pain, shortness of breath, and other things that I think are more soft but are really important as to deterioration, whether they're eating and drinking well, whether they're sleeping well, and you've got them over the phone and you can hear they're talking. You can generally hear a deteriorating COVID patient over the phone with their breathing and coughing. So just important to ask about those other things, eating and drinking and sleeping. So generally in the West, and I don't want to talk too much about the processes because I know several of you from interstate, it's going to be about notifying the relevant overarching body, which may be the public health unit or the hospital in the home service in your area. So in Victoria, all COVID positive patients will receive an SMS from Victorian Department of Health confirming their positive status, and there is a survey that patients fill in, and they then receive a second SMS which gives them their date of isolation. It is a public health unit's role to determine their end of isolation date and clearance. There used to be a requirement for a formal phone call from the public health unit on their day of the end of their isolation date, but now it's automated in Victoria with a text message. So as long as they've served that time, which is 10 days now in Victoria, then and they've met that isolation date, there's no other criteria. It's important as GPs to recognise those people for whom the onset of symptoms is much earlier than their test date. So if you've got an example we had recently was mum that had 2 little kids, and they all got sick at once, but for some reason only mum had a test. And then the kids this was back when it was a 14-day isolation, they had a day 13 test to clear them from their period of isolation, and they tested positive then, which if it was left to the automated system, then their isolation period would start on that date. So the whole family would be doing another 14 days of isolation. But because we'd rung and spoke to mum and she said, no, we all got sick together, and I don't know why she didn't test the kids. A lot of people don't want small children being tested. We're able to contact the public health unit. They could do a medical assessment of the whole family and give them clearance all at once. So it is important, if you feel that people have delayed testing and that their onset of symptoms is significantly earlier, that you advocate for them so they're not kept in isolation for longer than required. Some really important points, and it's a huge problem in the community that people think that they need a negative COVID PCR to clear them from isolation. They do not, and people who test positive for COVID may potentially test positive for up to 90 days. The longest someone has tested positive was 110 days. So repeat testing of COVID positive patients has no value whatsoever. So, and they do not require a day 10 or day 13, whatever isolation period your state is doing. They do not require a negative test to clear them from their isolation period. And importantly, in Victoria, they are exempt from all COVID testing for 90 days post initial infection. So this becomes a problem where workplaces are doing surveillance tests. Schools are saying, no, kids can't come back until they test negative. And we know that children, particularly in Victoria and New South Wales, have missed a large amount of school, and we need to be advocates for them to not miss any more school than they need to. And the other important point, which is another misconception in the community, is that people who test positive for COVID-19 need to delay vaccination. They don't need to. And a lot of people we've seen in Sydney and in Melbourne who test positive for COVID are doing essential work, which may be insecure, and they may not have sick leave, and so they require their vaccination status to get back to work. There is an exemption option, but from my point of view, I'm really encouraging people to just have their immunisation as soon as they're clinically well and cleared. There's quite good evidence now that immunisation provides superior protection against COVID infection over previous COVID infection. I think the risk of getting COVID infection from someone who has previously had the infection was 5 times higher than those who've had a vaccination course. And if you add boosters to the mix, then you're really providing much better immunisation than COVID infection. So it's important to express that to your patients. The other thing, people, particularly with children going back to school, a child gets COVID-19, does their 10 days isolation, gets clearance, and then a week later, there's another COVID child in that class, and the whole class is sent home as primary close contacts. So people previously infected with COVID-19 should not be identified as a PCC for 19 days. And often as GPs, we have to advocate for this because children are being sequentially locked out of school for 7 days in Victoria for PCCs, but we need to minimise children missing out on school, and it's often our job as GPs to advocate for that. These are just my thoughts around COVID-19. I'm going to finish on this. I think we all understand that COVID-19 is here to stay and will likely become a circulating endemic respiratory virus, either with epidemic or pandemic behaviour or endemic behaviour, depending on the future. Obviously, case numbers are going to fluctuate. So really management of COVID-19 is going to be part of GP bread and butter. And we're going to be seeing it all the time, just like we see chickenpox and flu and everything else. And therefore, all GPs need to be competent in managing COVID-19 in all people, pregnant people, children, elderly, immunocompromised, all of them. And managing patients as part of West Metro COVID Care Pathway or the relevant service in your area is a really excellent supportive way to learn to manage COVID-19 patients. You don't want to say no. We have a few GPs that say, no, I don't do COVID care, which is all well and good until the health department decides that this is a virus, GPs can manage it, and you're suddenly going to be managing COVID on your own. So this is a really good supportive way to upskill in managing COVID patients. The other thing, which is just my bugbear, having been involved in COVID and been involved in a lot of State Department meetings and found that GPs are completely left out of a lot of the pathways and health decisions. And often we have to put our hand up and say, hang on, we're GPs, we are really critical in our patients' care, and we need to be advocating for being included in the management of COVID patients, because I think for most people who develop COVID-19, it is a mild illness that GPs can easily manage, particularly with the addition of vaccination. So that is the end of my talk.
Thank you so much, Catherine. There's a heap in there. We've got some great questions in the chat. I might just come to a couple of them before coming to you, Elizabeth. There's a question about how GPs are supposed to manage patients remotely without pulse oximeter data, given that patients can deteriorate quickly. Can you just speak to that briefly? Yeah,
I think if they're, it's a really good question, and I think it would be ideal if everybody had a pulse oximeter at home and we could use that. But I think having managed a lot of COVID patients, if they're at the point where you're relying on their oxygen saturation to assess their well-being, then they're not appropriate for GP low stream care by telehealth, because it's just not good enough intensive care. So I think if you're starting to be worried that they're so breathless or coughing so much or fatigued that you feel like you'd love to know their SATs, then that's a trigger for you to escalate them up to the medium pathway.
Thanks, Catherine. And what about for patients that don't have a mobile phone? How have you managed that?
Yeah, I think that's another really good question. There are a lot of patients who don't have internet and don't have a mobile phone. And I think in that setting, that puts them into a higher vulnerability status. And I think, if they've got a landline, a lot of elderly people may not have a mobile phone, but have a landline. But if you've got no easy way to manage them by telehealth, then they're not, again, appropriate for GP care. And you may need to either move them into some accommodation where they can be managed on site, or move them into a care pathway where there's going to be a nurse calling in daily physically.
There are a few more questions. There's probably one more, and then we might leave the rest till the end. There's one particular one about furloughing, which was a huge problem for us in Victoria, until we worked very closely with the department to work with them to change the guidelines to be much more pragmatic. So we might come to that after yours, Elizabeth. But just another question around have you been seeing patients who are COVID positive low risk that need to be seen face to face for an examination that doesn't need to be seen in the emergency department?
Yeah, so there are GP respiratory clinics, which is what what they're designed for. So patients who need a face-to-face visit but can't be seen by their GP because they either have COVID-19 or they have suspected COVID. So you can, and the government in Victoria certainly is funding a large number of these as we speak. So that is one option, is to find the nearest GP respiratory clinic, because that's basically a hot zone clinic where everyone's in Tier 3 PPE and would be happy to do a GP assessment of a patient. I certainly in the early days was doing in-home visits for patients living in the high rises and things, but that's not really, there is a better model of care for people who need in-home assessment now, and that can be arranged by the hospital and home or virtual ward team, or it can be arranged by, if the patient's mobile and can get in their car and drive directly to a GP respiratory clinic, that's another option.
Thanks, Catherine. All right, I might move on to Elizabeth, and we'll try and answer some of these questions in the chat, in the Q&A, sorry. Thanks, Elizabeth.
Sorry, I was just having trouble unmuting myself. Hello, everyone. I'm Elizabeth Williams, and I'm a GP in Melbourne's northern suburbs. We're just a standard general practice. We're a large private practice. We've got lots of doctors, but we've been managing COVID positive patients through these primary care pathways now for the 2 years of COVID. And I guess what I want to say starting off is that Catherine's talked about a particular model that we have in Melbourne, and you may not have those models set up yet, or they may not be fully in place, you might not be aware of them, but the principles of the management are the same, whether there's a formal model to support you or not. And I'm going to talk you through that with some case studies as well. We'll talk about some management, primary care management. We'll talk about what clinical assessment you're doing, your red flags, and a little bit about what we do after they're cleared from discharge. And I'm going to use some case studies, and our first one I've called Belinda. She's a 41-year-old mother of 4. She had her first Pfizer on the 9th of October this year. She started feeling unwell 3 days later, fairly non-specific symptoms, and clearly she thought they were vaccine related. She had myalgia, fatigue and headache, and then she became congested. She rang our clinic on the 15th and she said she felt just a bit unwell, and the doctor talked to her and thought could have been vaccine side effects, more likely perhaps a viral illness, suggested that she have a COVID test. And she did, and of course she tested positive for COVID the following day. So I guess the first thing I would say about COVID is you've got to think of it and you've got to test for it to diagnose it, and don't, the number of people who come and say, I'm sure it's this, it's not COVID, it's just my asthma, it's my vaccine side effects. If we don't think of it, we won't diagnose it. And the clinical case definitions, I'm sure you all know: fever without another explanation, respiratory symptoms that are acute, so new onset respiratory symptoms, that tries to exclude those with that chronic cough, but also importantly, loss of smell, anosmia and loss of taste are key, warning signs that it could be COVID. So, we thought of it in this case, we tested for it, and sure enough, she had it. And older people may present with quite atypical symptoms, including just sort of functional decline or a delirium, just looking a bit off, and we've certainly seen a bit of that too. And as Catherine said, when we first diagnosed the COVID, now this could be you've diagnosed it because you've seen them in some sort of assessment clinic or done the swabs yourself. It might be that you get a call from the patient telling you they've had a test in the community centre and they're positive, or it might be that they're actually managed through a formal pathway and you're notified formally of a positive diagnosis. They need that initial assessment to work out where the best model of care is. And of course, general practice is the best model of care for most of them, but not for all of them. And that initial assessment, as Catherine took us through, based on symptoms, but also risk factors, and equally importantly, what are the barriers to isolation or what social factors might be going on. And so this idea about we're determining risk, it just says what's the potential for them to deteriorate. And that risk at that initial assessment might determine where they get cared for even from the start of their illness. And obviously if they're high risk because of their symptoms or they can't isolate, they may require inpatient care from the start. Or as she's outlined, if they're more medium risk, they may well be best managed through a hospital-led home-based management system or a virtual COVID ward. And this is some of the things that you might be considering to think about risk, and Catherine's already taken us through that. But we're particularly, and some more of this is around what are the reasons why they might not be suitable just from a social perspective. Again, housing issues if they're in a household with lots of people, mental health concerns, financial stress. They're the things that we need to think about all at the start of the diagnosis in terms of how we're going to manage from here. Because what we're looking for, of course, if those who are low risk patients are fully vaccinated and under age 75, or they might not be fully vaccinated and they're a bit younger and they don't have any other comorbidities, or if they do, they're mild, such as diabetes not on meds or asthma without preventers. They're not too sick and there's no problem with barriers to home isolation. These are the patients who are ideal for primary care management. And this represents about 80 to 85% of people who have COVID. We're going to be doing more and more of this sort of thing. So getting back to Belinda, She was determined to be low risk. She was initially assessed through the local health service, low risk. They referred her formally to me for management under a formal pathway. She was referred to me. She was actually my patient, and our practice is we will manage any of our patients, and we try and get their usual doctor to do it, and if not, one of the other doctors in the clinic will do it. So she came to me. Now, when I rang her, I said, oh, how are you going? Are you isolating from the rest of the family? She said, Elizabeth, that ship has sailed. The whole household was symptomatic when I rang her, and they were all tested. As Catherine said, they were all tested as soon as possible, and they all subsequently, over 2 or 3 days, came up with positive tests. She, her partner, and her 4 children aged 15, 13, 11 and 6. So what's our role? As we've heard, it's to monitor through a telehealth system, how are they going, and to particularly look for deterioration, and then appropriately escalate care as needed. But I think a very important part of our role is to provide reassurance, education and general advice. People are scared of their COVID-19 diagnosis, and they need some good, sensible advice. We need to help them with their isolation guidelines and review their social circumstances. We're not the quarantine police. It's not our job to report breaches of quarantine necessarily, but just to keep reinforcing the public health messages around isolation. And if they are in a formal care program, such as the ones we typically do, there is some formal reporting required in terms of doing an email survey each day, just to let the public health unit know that we are looking after them. And at that initial assessment, it's important to take the time to be clear about the COVID timeframe. Catherine's talked about why that's important, because in the second week of the illness is when the risk of deterioration is, and you need to understand the date of symptom onset, which may well be quite different to the date of the positive diagnosis. So get your timeframes clear. When did they first become unwell? When was their positive test? When did they first isolate? And if they are asymptomatic, then the day 1 is the day of their test. Then, of course, you need to ask about how are they feeling right now. And as Catherine said, at that point, you might be calling an ambulance because they're very unwell, but hopefully not. And again, if you are doing this first assessment, you must consider whether some other treatment is required. And I'm not going to go through the criteria again for sotrovimab treatment, but if you're the only person talking to them in day 1 to 5 of the illness, it's on you to recognise that they may well benefit from that. But then you also need to do some things, again, that general practitioners are very good at. Think about what's going on in the household. Now, I urge you to check your contact numbers at this point. The number of times I get to a few days in and I realise I can't get onto them and I don't have a next of kin details. Do this at your first assessment. How can I get onto you? And if I can't get onto you on that number, what's the next best option? And who can I call if I really have trouble finding you? But importantly, and there was a question about this, ask who else is in the house. Who else is in the house? And in particular, what young children are there? The children often aren't in a formal management program, and it's on you to review them. But at this first point of contact, ask the question, what would happen if you and the other adults in the household became too sick and were unable to care for your child or children? It's recommended that at that point you nominate and document an alternative care arrangement. And that might be a vaccinated friend or family member who would agree to come into the household in that scenario, or to take the children into a separate household. In rare instances, well children are admitted to hospital because there is no other care option available. So it's worth asking at that point and helping the parents think about that question. And I'll touch on that a bit more with my case study as we keep going. So ask about the dependents. And in fact, in Victoria, there's now a formal referral program. If we identify that a child does not have a suitable care arrangements there, we can refer them to a program which will help place them in a suitable setting, which may well be admission, or it may be another setting. and I said I'm not going to go through this again, but, you know, think about that, look up those guidelines, work out who in your community is doing it, which hospitals, how do I refer, and just have that at hand to check on. So we've done our initial assessment. We've decided that they meet the criteria for low risk. We need to give some initial information and advice. Make sure that they understand that they've got COVID. Use that phrase explicitly. Tell them they need to stay in isolation until they're discharged, and that it's not that you, the GP, that's discharging them, it's the public health unit. And also that their household close contacts must remain in quarantine for the designated time frame. And in Victoria, that's just changed to 7 days for vaccinated household members. But make sure that everyone understands what the quarantine requirements are. Discuss with them, at least in a broad overview, the likely course of the disease. Explain to them that you'll be particularly monitoring their symptoms during the second week, because that's when deterioration can happen if it occurs. And let them know that we're particularly interested in breathing difficulties. You need to be explicit with them that they are allowed to call an ambulance and seek emergency treatment if they become very unwell acutely. I've had a couple of people feel like they can't do that because they've got COVID. And so make it very clear that they are allowed to call 000 and say, I've got COVID and I'm really unwell. They have to, of course, advise the diagnosis so the ambulance people can be appropriately protected, but be explicit with them as you talk through this in the first days, that that is what they're allowed to do. And in fact, of course, what they should do. And give some general advice about symptom management. It's a viral illness. Antibiotics are not indicated. You might need to manage your fever with paracetamol or ibuprofen. Stay on all your regular medications, including your ACE inhibitors. Stay on your asthma medication. If someone's on immunosuppressants, they may not actually be low risk and be managed by you, but if they happen to be, you might need to seek advice from their rheumatologist about whether they're going to withhold one or more doses of their immunosuppressants. So you can get specialist advice if you need to. Reassure them that there is no specific treatment for mild COVID and that they will get better. I'll pause there because I was going to say will on the whole get better. I don't suggest that's what you're saying. They just, reassure them that you will be monitoring them and they will be carefully cared for. So Belinda, she actually did feel quite unwell during her second week of her illness. I was ringing her every day. And in each review, I would ring once the whole household and I would ask about her. She was the sickest. I'd ring her. I would ask about her partner and then each of the children. The children had mild illnesses, as is typical for COVID. One of the children had some vomiting, so I was more careful about monitoring her. That resolved over a day or so. Belinda was feeling quite unwell, weak, shaky, feeling like her heart was working hard when she exerted herself. She started coughing in the second week, as they typically do. And then I don't actually think she was feeling completely well. I'm not sure what I mean by that, but, still reduced sense of loss of smell in that second week. Day 10, she said she felt crap when I looked at my notes afterwards. Day 11, things started to improve, and that's often the point where you see things turning around. She was feeling tired and still having a daily nap. Day 13, she was still congested. Day 15, she said she was much better overall. I had spoken to her every day for about 10 days at that point. She was discharged by DHS, as were her partner and children. So don't need to reiterate that, but I guess the key things are GPs in Victoria don't clear for discharge. That's not our role, it's the Public Health Service, and that the swab, Catherine's talked about that really clearly. Now, I saw Belinda the week after she was discharged from her isolation. I did a full examination, reviewed her physical and mental well-being, and she had her second dose of Pfizer at that point, really only a couple of days after she was released from isolation. And her illness would be characterised by mild, although it was a very unpleasant experience. Now, I mentioned about asking what would happen to the kids if neither you or your partner could care for them. That family had a day where the children had cereal for breakfast, lunch and dinner. The parents could not do more than provide cereal. And I was happy to let that go for a day, but clearly that wouldn't have been appropriate to allow that to continue. And so, what is your contingency plan in some of those scenarios? Let's think about Susan now. My second case, she's an admin assistant, unvaccinated, perfectly fit and well. Her father, elderly father, became unwell with COVID, was admitted to hospital. She had a test as a close contact and was negative, but then a few days later, she maybe got a scratchy throat. She didn't test immediately. When she did test, she was positive. And by the time she was referred to me, she was actually day 7 since her symptoms had developed. She had that initial assessment, as we've talked about, risk factors, barriers to isolation and symptoms. She was also considered low risk, and I rang her for further monitoring and review. So let's think some more about what that further monitoring and review is about. The frequency of contact, there's no hard and fast rules. We say regular. Certainly you want to make contact at the time you're notified that they're positive, really within one or 2 days. And then in the first week, probably every 3 days is adequate. But from around day 5, you want to start picking up the deterioration. And so a review around then, and then until symptoms resolve, at least second daily. Most of those people who are more unwell in the second week, I will ring daily. Now I say I will ring, but sometimes I will hand them over to a colleague who's working on the weekend and get them to do the calls. At other times, I would just make the calls myself all week. Prior to weekends, if you're not planning to ring them over the weekend, it's very good to have a point of contact on Friday to determine if you do need to arrange some handover of a weekend. And obviously, if you're not there, think about who's doing it. So before each call is finished, I will say, I will be calling you again on whatever, tomorrow, 3 days time, and I'll make that assessment based on what's happening. But make sure you're clear about when that next review is. Don't leave it up to them to contact you. Be very deliberate about your review. And I just want to remind you that in terms of telehealth, the existing patient rule does not apply for those who have COVID or who are isolating because of COVID requirements. So even if you haven't seen them in the practice for more than 12 months, you can perform telehealth and bulk bill that well, you can get a Medicare rebate for that. Okay, at each review, what are we doing? We're asking about symptoms, the old symptoms that we know about. What new symptoms do they have? What are the signs and symptoms of deterioration? And has anything changed in terms of your ability to isolate? Are they running out of food? Do we need to help them problem solve a grocery delivery, a medication delivery? I've, faxed a letter to the pharmacy saying my patient has COVID and they've run out of paracetamol. Could you arrange for someone to drop it off? Whatever. Help them be problem solvers in that regard. So at each appointment, these are the sorts of things you're doing. There are clinical scripts and templates which you can use, but basically you're covering OBS if they've got them. The Apple Watches these days can give you a heart rate. You can turn to a video call if you want to watch their breathing or perhaps count a respiratory rate. I agree. I think we all should have an oximeter in our back pockets, but if they've got access to an oximeter, what is the saturation? Ask about their symptoms, and whether they're, worsening or present or not. But some specific shortness of breath questions are really important. Questions like, is your breathing different from yesterday? Can you walk at least half as far as you did yesterday? Can you lie flat without worsening shortness of breath? Is your breathing disturbing your sleep? Now, on the clinical scripts that I've looked at, they actually leave off mental wellbeing assessment. I actually think this is a crucial part of COVID management in general practice. These patients are anxious. And so asking, how are you going? Are you sleeping? Are you worrying? Providing the appropriate support and reassurance is very, very important. So ask about mental wellbeing at every point of contact. And then think about deterioration, particularly asking, how do you feel compared to yesterday? And you're, of course, getting a little alert if they're saying, I feel much worse than yesterday. So we need to be listening out for those things. The red flags we're particularly looking for is new or increasing shortness of breath, particularly, as Catherine said, walking within short distances around the house. Chest pain or tightness, pleuritic chest pain, syncope or near syncope, an altered mental state or new onset confusion, severe weakness, hemoptysis, and consistently missing more than one meal a day are all red flags that things are deteriorating. And remember, that can be seen from days 5 to 10, but can even be a little bit later than that. So at each point, each time you're in contact with them, you need to decide for yourself, are they stable? Are they deteriorating, or are they improving? Am I going to continue my care? Am I going to escalate their care? It might be that I'm calling an ambulance, or perhaps I'm contacting the local hospital in the home service and saying, look, I think they need more intensive monitoring, and you're escalating them to a medium level care. Or it might be that you're de-escalating. I'll give you a call in 3 days' time or 4 days' time. Or even, it's time for us to stop talking. We will see you in the clinic. You obviously have to do your reporting if you've got something in a formal program, the electronic data forms where applicable. You may have Health Pathways. Health Pathways Melbourne is excellent. I'm hoping there's things in other states. It's a brilliant resource in terms of COVID management. You can see some of the headings there: long COVID, post-COVID review, primary care management program. And Catherine and I work under the West Metro one. But the RSCGP has also put out some home care guidelines for adults with mild COVID. And there's a PDF document that you can also share with your patients, which includes some symptom monitoring resources. And this is one from last year, and, using same, worse and better for just monitoring symptoms. Some patients find that really empowering to have a way of formally recording that. So Susan, when I first rang her, she had a fever of 38. And in fact, she had a fever of 38 for 8 days. She had nausea, fatigue, a bad headache. She'd lost her sense of smell and taste. She was clearly actually quite unwell, quite systemically unwell. When I spoke to her each day. On day 10, she was much more breathless. They had an oximeter, and it was reporting less than 90% when she was resting in bed. I was quite concerned at this point and called an ambulance. They attended for an assessment, but they didn't take her to the ED. And that was reflective of, I think, Victoria at the time with our overload of cases. They did a full assessment. So they entered the house full PPE, did a thorough assessment, including an ECG, and were happy to say that she was okay. And I spoke to her twice a day for a couple of days at that point. I could have also escalated her to hospital in the home, but she actually turned around quite quickly. Resting in bed day 11, day 12, but all right. And the breathlessness had actually dropped off quite quickly. Day 13 felt she'd turned a corner. Day 14, each day was a bit better. She'd actually got some gastritis because she's used so much NSAIDs for her fever management. And she was discharged from isolation on day 16, which was 10 days after her positive test. And this again reflects what was happening last month, which has changed slightly in terms of how long people were in isolation for before being discharged. Her illness, I think you would say, was moderate based on her symptoms. And again, we brought her in for review 2 weeks later, at which point she said she was 95% better, still some residual symptoms. She requested a vaccine exemption for 6 months. She felt very traumatised by the whole experience. I'm running out of time, and so I'm going to move through Matilda. Matilda's a case from last year who had no contact, no GP care, occasional text messages from the health department, and saw me 4 weeks later with ongoing post-COVID things. And we don't really have time to talk about post-COVID management. We've talked about what makes a mild illness and a moderate illness and a severe illness, and the vast majority of people have a mild illness, and you can look those up on the Clinical Evidence Task Force website. But in terms of post-COVID care, I do urge you to bring them into the clinic, everyone, after they've been cleared from isolation. Talk to them about how they're recovering both physically and emotionally, examine them, and then perform further investigations if they're indicated, because long COVID is a very significant problem. And I'm just moving through Matilda's case because we don't have time to talk about her. In Matilda's case, all her tests were normal, but she was not normal. And that was a very difficult thing to manage because, as you can imagine, you feel like you failed by getting COVID, and then you feel like you failed again because you didn't get better from it. long COVID is definitely a thing. We're seeing it more in general practice as we've managed people who've had COVID both last year and this year. And it's very tricky. The evidence is, there's not good evidence to guide our management, but maybe up to 30% of people will have some symptoms there. I'm going to move through my slides just to my take-home messages. Firstly, mild illness is not necessarily mild, and both our ladies were not hospitalised, but one of them had a much more significant illness. There's a lot we don't know about long-term effects of COVID, and it's worth finding about local post-COVID services, including rehab services. And thirdly, be aware of the health impact of a positive diagnosis. These people are anxious and we're ideally placed to support them.